Raleigh today, and we are excited to bring you You Asked, She Answered, or we'll do our best to answer, but it's mainly about Dr. Roughton. We were just talking about our favorite shows, perimenopause, and your training workout schedule, as well as your outfit before everybody got here. So this is going to be random and fun, but we're mainly going to talk about the most common but honest questions that are asked in Bustmob surrounding breast implants and lifts, and really all the things around that, like healing, expectations, anatomy. We were first talking even about goal photos. Like, that is such a tough thing for so many women. So you are always one of the most candid humans and so easy to talk to. So we are very grateful for your time today.
Cool. Well, thanks for having me. It's been a while. I like this new setup.
Yeah. So you
It's not
said
just me on my phone on some sort of weird stand trying to like not show the ceiling or whatever. So,
but you did let us know you've got a hard stop.
I have a
By
hard stop at 5 because I got to get to my trainer. So I made Gretta laugh because I knew it was hilarious. I've been operating all day and I had just a second. I didn't have time to go home after this to change clothes from scrubs into my workout outfit. So I thought, no problem, I'll go put on my workout outfit and then I'll come back and do the Bustmob live. But I wasn't sure what I should wear because I didn't really think you wanted to see like my t-shirt. So I like came back to COVID days, and I was like, oh, I'll put a blazer. They're only going to see from the top. But then it was so funny when I walked through the building and I was like, Greta, watch. Let me just get back a little further. You see the workout outfit?
It is perfect. It's what we have to do. The amount of times I change in my car, or I have so many clothes in my car, I understand. Good for you for
Thank you.
sticking
So I'm just
with
trying
it.
to make it all work because, as you know, at 46, it's not going to work itself. So I'm trying to eat my protein and go to the trainer, and I rub the estrogen patch a little extra if I'm feeling stressed, get a little bit more out of it. All that.
Yeah, we can do a whole side live at some point about all the things we are trying, rubbing on ourselves and injecting in ourselves right now to just be normal. So that's a whole nother conversation. But we both have implants, and we can talk about our perspective of that too. So let's dive into the most common, like you and I were even talking about expectations prior to your consultation even, and being in Bustmob. So consultation, expectation, mindset before you're coming in, like, how do you find goal photos? Are they important? Do surgeons find them important? When you see them, how do you kind of navigate that conversation of realistic, unrealistic? Like, again, it's the fastest surgery we do. I think you do, one of the fastest surgeries, and the one we spend the longest talking about because of the customization when it comes to implants and the look. I know it was the hardest thing for me, and I've had 5 exchanges. I mean, over 22 years.
Fair. I have the same implants that I've had put in the first time, so don't worry. I've had them in for 11 years. They're doing fine.
I'm an Enneagram 7. I like to change it up.
So I think you'll find that each surgeon has a little bit of their own style, like whatever works well for them. But I think that what has worked the best for me, so initially it was like engage patient in conversation and listen to words that would describe what she wanted. But I ran into a little bit of trouble with that because the word natural means something very different to different women. And I only figured that out when I said, okay, well, show me a picture of what you like. And I will never forget it. This woman showed me this picture of this woman probably didn't weigh 100 pounds and she had giant implants. And I've been hearing patients say, like, it looks like an AirPod, which I thought was a great descriptor. And I was like, does this look natural to you? And she said, well, no, not really natural, but it looks great. And I was like, okay, good. So let's get rid of the word natural, because I think for some women, natural means I don't look like somebody would point at. Like, okay, good, but I'm not gonna hopefully be participating in anything somebody would point at. So let's work within that. And so for me, it's super helpful. I don't think it's as important to find your age or your current cup size. I just want to see what you like. When you look at something, if you think, hey, if I look like that, I'd be really happy, awesome. I think it's helpful to have like less than 20, because at some point we got to get them a little narrowed down. And then it's pretty easy for me to be like, all right, this group of people is a little smaller, this group of people is a little bit bigger, which is your preference? And then we can kind of work from there. So some things that I look for are volume. What does the top of the breast look like in your photographs? Does it look a little bit more natural of a slope, or does it look very round? Because that we can adjust some things for people to look one way versus the other. I think that the unclothed pictures are the easiest for me to assess, but I know sometimes you're not used to looking. I mean, I have a weird job where I look at naked people all day, every day. So bathing suit pictures are probably, or bra pictures are probably the next best. And I think it's much harder if you're wearing a whole lot more than that. I think that sometimes the angles can be tricky. So if the person took their picture like this, that's not as helpful as something that's a little bit more, looks a little bit more medical, like it's taken straight on or from the side. And then one of the harder conversations I have to have, but it's a super important conversation and you have to have that, which is if you start with a full low breast and your wish picture is someone who started with no breast at all and a small implant, like I don't have the capacity to turn low heavy breast into small, very round, petite breast, like, because the starting point is different. The amount of breast tissue that the patient is starting with is very different from the one that they wish they were starting with, type of thing. But that goes so well if I just know up front, okay, we can look similar to this, but not exactly like this. We might do something different. Like you probably don't even need a breast implant type of thing to get to this volume.
What about if somebody's body style is super different? You know, you have a really wide rib cage, or you're heavier than you'd like to be right now, but so many of the goal photos are of these tiny women. Is that still helpful?
I think it is, but it's, I'd actually just put in a plug to put your pictures in Goal Finder, because part of it is the people that feel the most confident in, I think, in posting pictures of themselves naked with their implants are teeny tiny girls with medium to large implant sizes. Well, that leaves out, 90% of the population. And so it is harder. It's not that the patient thinks that I look like this 17-year-old right here, but I can't find anything else, and it looks great. So sure, if I could look like that, that'd be wonderful. And I know you and I were talking about this before, but I think it's a different patient, like patients that have breast reductions or patients that have lifts without implants. I think that they are less in the world of, man, I sure would love to put my breast on the internet. I think a lot of patients with breast reductions have been hiding because their breasts are so big. They've been having poor posture, hunching over. They don't want to be seen. They don't want their breast to be the thing that people see. But now we're going to do the surgery, and they're quite happy. But when it's like, hey, can we share your photos? So it's like, oh, you're out of your mind. But that then makes it hard for the next person who's then looking for, hey, what would a breast reduction look like on me? And it's just a plug. It doesn't mean everybody has to, but if we got 20% more to say yes, that'd be amazing.
Do you still, if somebody's not getting an implant, so they're getting like a reduction or a lift with no implants, do you still want goal photos?
Yes, I think it's very helpful for sizing. So I think, let's start with breast reduction. Because breast reduction, it's not the exact same as like, hey, I'm going to take this 500 cc implant off the shelf and put it in your body. I don't just take away 500 cc's like a hamburger and take it out. But it is helpful to get an idea of what is your brain thinking when you think I want smaller, higher breasts. Well, how much smaller? So it's a data point that then I can try to help you with your anatomy. Like, is that reasonable or not? And so similar to it's not reasonable with the implant thing. Like if your breast is extra large, it's very difficult to impossible to make that extra small in one step. However, if you started with maybe medium, but it was too big for you, well, sure, you can get to extra small. And I'm making up these terms because I don't have better ones. The other thing that we've been using in the office that has been a game changer for me is something called Chrysalix, and it's similar to the vector that we used to talk about with 3D imaging. It's just a better program. It's like PlayStation versus Atari, and we can simulate amount of grams off in a breast reduction, which again, it's not perfect. It's not a great science, but if I have a picture and I know that you thought 500 grams off looked good, 700 grams off looked too small, 300 grams off wasn't big enough, well, man, I got something to shoot for in the operating room that's an objective measurement. So I've been using that a lot. I don't know that everybody is. Then for the lift, what I look at when I see wish pictures from breast lift is I look at the top of the breast in the wish picture. And nothing to draw on you. My kids camp.
Yay, I love your drawings.
Camp for would be perfect.
It
Um,
is camp season and immunization and pediatrician season. I'm in
if
that
your
too.
goal is this shape after a breast lift at the top, fantastic, because that's what it's going to look like. If your goal naked is the dashed line, I don't know if you can see it really well.
Mm-hmm.
After a breast lift, I need to add a breast implant. Like the breast itself, this gel is more cohesive and it's not really as affected by gravity. Natural breast tissue is affected by gravity. So it's just another opportunity to say, hey, I like that too. The power went out. I'm fine. Well, my computer's on, so maybe it didn't. I don't know.
I think, doesn't it go off if you don't move a bunch? Try moving.
Not in here. I'm not
Oh, I
going to
thought
do
you
that.
had
I know
to
you're trying to get me to wave my arms around like an idiot. And I'm not gonna do it.
I want to see your outfit again.
That was a one time. I've seen it twice.
I'm glad we're talking about anatomy because that keeps coming up too when we're talking about smaller implants right now, or we're talking about Preserve. And Bustmob is getting more and more educated on Preserve. We all are. I'm learning. But obviously that only goes up to, you can only do the Preserve technique, correct? If for smaller implants.
That's right.
But what if, how do you know if your rib cage is small enough, to fill up that space? Like, do you recommend people finding out their breasts with diameter or BWD to figure that out?
No, in fact, it causes me stress, and then I know I caused the patient stress because I measure it at consult, and I'll often measure it again, and they're like, "Well, that's not what you said the last time," and I'm like, "Yeah, I know, it's fuzzy," and so, especially for Preserve, so what that is, I don't know if everybody knows what that is, but it's using a balloon sitting inside the breast to make a space for the implant, rather than cutting through all the connective tissue of the breast. Benefits being, in my hands, it means an over the muscle doesn't ripple. Fantastic. And it also means, we think, but I don't have anybody 5 years out because I've only had it on the market for less than a year, but we think it will have less lateral displacement when the patient lays down and less lower pole stretch when the patient stands up, because it's not violating any of the connective tissue type of thing. So small implants, it also, for me, it's not a big deal. I don't mind anesthesia, but a lot of people are scared of anesthesia, so I can do it with you completely awake, which is nice, right? Like if that's important to you, or just a little bit of sedation, if that's important to you and alleviates a huge stressor, then let's do it. So how do you measure for Preserve? With Preserve, whatever your normal base width would be, kind of from just on the other side of your sternum to the front of your arm, it's generally about 2 to 3 centimeters smaller because you're taking into account the fact that you're leaving all the connective tissue of the breast. I've always thought of base diameter as a bit of a fuzzy thing. There are people that feel like it's more scientific. There are people that measure it in the operating room. Like I haven't found that to be helpful for me. I'm not saying that that's wrong for other people. I think we all just, again, every surgeon, reputable surgeon, is going to want to keep you safe and make you happy. And then there will be stylistic differences between people, like there is for everything. Did I answer your question? Oh, how do you know? Oh,
yeah.
Sorry. A little ADHD is just, it's coming. So in general, yes, smaller volumes, but you wouldn't put a teeny tiny golf ball looking thing in somebody as wide as I am, right? Like you would have to be much more petite for the golf ball to look right. So what I typically do is just play with the profile then. So the flatter implant, the mini would be equivalent to a low or a low plus in a different brand. The flatter will be wider and typically looks really good. These aren't patients that want really round breast. They typically want to fill up what they've lost in the upper pole with pregnancy, nursing, age, weight loss, whatever those, combo is. And so a flatter, you've got a breast on top. The flatter implant it's a lower profile, so it's wider and taller and fills up the upper pole really nicely. And then as you want the higher volumes in Preserve, you would look at the demi or the full profiles, because those will give you more volume without getting too wide.
Do you think people are you noticing a trend with profiles going down in a way? I feel like everybody used to talk about high profiles, and now so many people are going for that, side boob, but flatter. Like they don't want projection anymore.
I do. I will say it is interesting, right? Like I do a lot of breast implants, and I love doing that. Um, the middle, I think, has always been the middle. It's kind of like in politics, like most people are actually right in the center. And the most common size I think I think we've looked at it before, is right around like 350. Like,
Mm-hmm.
not a big implant, though
Yeah.
there's a bias if you look on Bustmob towards really big implants. Again, I don't think that's because I do a ton of really big implants. I think it's because the patients that have the bigger implants want to share it more. So you get a bit of just a math problem.
Mm-hmm.
However, I will say that, so the middle is still the middle. However, I have never had patients come in, and I think it's Preserve is doing a lot of it, who are like, no, really, I want 150 cc's. I was like,
Yeah.
they make those, which I know they
Yes.
do, but that's been new for me. But the majority continues to be the middle.
Got it. Yeah, I have been seeing that too, and I'm like, what? This is just so wild. But you're right. It probably 350 is a very middle size. So I also wonder if we're all getting older, and I'm communicating more with older people, and they are just, we're in that season. I got mine when I was 25, but I'm 48 now, and I want to downsize now. And I'm like, I just wonder if I'm all hanging out with
It
old
could
people.
definitely be that. I don't know.
Can we talk about areolas too? There was
I would love to.
a bunch of questions
Okay.
about surgically changing the size, the fear of the scars. Can it be done with the breast augmentation? What if someone's unhappy with some of these questions were puffiness, asymmetry, or just a larger areola size? Is it an additional cost? If you're
Okay.
doing it at the
Whew,
same time.
this is a lot.
That was a lot. Just all
We'll
things
get around it.
nipples,
I know.
areola
Buckle
nipples.
up. Or is we do these things where we come down with the band. Okay. So areolar diameter typically gets changed with a lift and with a reduction, because you're going to cut around the nipple and move it. In general, in those operations, you're going to get rid of some of the square footage. I can't think of the word, but you're going to get rid of some of the breast skin. You're going to make the breast more compact and tighter area, something like that. So if we left it the size that it is right now on the larger breast, it would look strangely disproportionately large. So we do tend to make the areola smaller when we make the breast skin smaller. So that is very easy, and honestly, it's not rocket science. And I tell the patients this, I have a small and a medium cookie cutter downstairs, and I generally will flash them and be like, this is the small. Do you like this, or do you want it to be a little bigger? And that's how we decide, because it's easy. I'm carrying around the model all the time.
Thank you.
The other questions are more challenging, which is essentially you described a tuberous breast. A puffy areola, tissue behind the areola, enlarged areola relative to the small breast volume. Typically, those patients also have the breast looks a little bit more triangular. There's a short nipple to crease distance relative to the nipple to the top of the breast distance. It varies a little bit on how to treat those patients based on the severity of the tuberous breast. Simplistically, in general, what I think is a bad idea is a donut breast lift, where you just cut around the areola. Because even though you may be doing it with the intention of making the areola smaller, and you may be taking areolar skin away, you're at the same time putting an implant in and stretching the breast. It's the opposite of, I'm going to get rid of the breast skin in a lift or a reduction, so let me make the areola smaller. Now you're going to cut around it. Scars at best are 80% as strong as the skin before you cut it. Where do you think, what's going to happen when you stretch the skin of the breast and you cut around the areola? It gets bigger than it was to start with. So I would tend to not do a donut breast lift. Asterisk, there are a couple of exceptions. One of them is severe tuberous breast and a relatively small implant. Yes, they have too much areola. You're not going to stretch the breast enough. Yes, you should take it away. That's a very rare, like I've probably done that 2 times in my career. I usually do something different from that.
Got it.
I would say, so I didn't answer the question. So meaning, if you don't need a breast lift and all you want is an implant, theoretically, you could stage it and come back and do a donut breast lift once everything is stretched out. Even so, I still think it stretches, and I generally think the lollipop makes sense, because when you bring that together, when you bring that lollipop together and you have the vertical component, so you're around the areola and down the breast, that incision that's going up and down is preventing that circle from taking all the stress and all the stretch, and it keeps the diameter smaller. And that vertical limb will fade.
Where are we at with scars right now? Like, what are your current recommendations for best scarring? Because I do think it's getting better and better.
I hear you. I am a terrible skeptic in general. And so, and I never want for patients to believe that there's a magic cream that's going to make their scar go away, because it's not. You're always going to have a scar there. When I say fades, it means it's harder to see. But and I have faded, my scars are faded out from the surgeries that I've had. But if you get up close enough, you can see them. So I think the goal would be faded, not very noticeable scar. Something that you wouldn't see from 2 feet, which is normal conversational distance, but you could see from 2 inches type of thing. So that's best case. I think we have to ask ourselves, what is it about the scar that we're trying to avoid? Is it a raised? Is it a color? Is it a width thing? And then in general, tension and preventing tension across the scar is the best way surgically to have a scar you would expect to heal well after the surgery. So tension across them is not ideal. The other thing is ideally, you don't want like a lot of foreign material in there, whether that's hair follicles, whether it's extra suture, stuff like that. The longer there's inflammation, the worse the scar is going to be. So let's say your surgeon's in charge of all that. So we do our damnedest, and it still isn't perfect. Color, red color tends to fade if you give it enough time, and fair-skinned people tend to have redder scars for longer because it's just inflammation. It's more blood flow in the scar. Our skin is really pale. There's nothing to really disguise the red color. However, some lasers, things like BBL, broadband, PDL, pulse dye. There's a lot of laser therapy that targets red blood cells that will help your scar get less red faster. I don't know that it gets to a different endpoint than it would in time anyway. But if it's bothering you, certainly you can look into lasers for scars. That was color. Let's say the scar is dark instead of red. That's a little bit more challenging from a laser perspective. Sometimes hydroquinone works well on that, which is a bleaching cream. And you would tend to do that a couple of times a day for 6 to 9 months and then give yourself a break. Mixed results from that. I think dark scar is a hard problem to solve, at least in my hands. Thick scar, especially thick, itchy red scar, like a hypertrophic scar, the first thing I try is a steroid injection. And then if we're making progress, we might do that maybe 2, 3, 4 times. If we're not making progress, my next step would be cut it out and close it again, because often there's even less tension across it the second time because you're not doing all the undermining and tissue rearrangement in the scar revision stage. If that doesn't work, then my next step, we've gotten a new toy here at Amelia, Raleigh anyway, which is a CO2 laser, which I've started to laser some of those patients. There's good evidence in hypertrophic scars that CO2 laser can be effective. Now, they're using a validated scale for scars that is probably not the same thing that my patients, like if their VASS, their VAS score goes down, like they're not going to say, thank you so much. They're trying to have an invisible scar. But those scar scales measure how thick the scar is and how itchy the scar is and how compliant the scar is. So think about somebody, for example, that may have had a burn across a joint, and what they're measuring is how much is that preventing their movement. So that's not exactly the same thing as I had a tummy tuck and man, I wish my scar was slightly less visible. But I still think it's helpful, and that is also done in series. Then I think there's thing I didn't mention is massage and tape and sun avoidance. So it's probably less likely that some magic cream penetrates the intact skin and somehow makes, changes the scar healing than it is that rubbing in the cream, whatever that may be. See, when I'm doing this, I'm creating friction. So I am creating increased temperature and pressure across my palm or wherever I would be massaging the scar. The more you like the cream, the more it smells good, feels good to you, the more you will use it, the more you are massaging it in and creating temperature and pressure, which has been proven to help with scars and collagen remodeling. So I would say use whatever you like that doesn't irritate your skin. So it doesn't need to have a bunch of, this isn't Bath and Body Works time for your fresh scar, but like something it could be Aquaphor, it could be the scar creams, because it could be the scar salve. Like all of those things are organic and they're not too bothersome to you, and you like it and it smells good, so you're going to use it. I think that or paper tape works well, but nobody wants to keep paper tape on their incision forever. Silicone strips that you can buy in the drugstore in the scar section, those things are increasing temperature and pressure locally at the scar, which I think has been shown to be helpful. So I'm not anti-scar cream. I just don't know that is truly, like, if we're going to dig one layer deeper, I do think that it's the actual using it. And that works for them. By the way, all the creams that I buy in the med spa that I don't actually apply, it turns out you have to put it on your skin. Wild. Keeping it on the bathroom counter does not work.
I'm shocked you're not that compliant. I use 12 products every night.
I am now. The getting ready for bed thing has taken a long time. I got the bedtime supplements. I got the skincare. I got a whole thing that it's got little.
I was gonna. Okay, are you using a bonnet?
Not a bonnet. You mean to sleep in?
Yeah.
No.
It has changed my life.
Well, your hair does look great.
It does, and I'm not saying like it's because of the bonnet. I'm like waking up like this.
Wow.
Nick can't stand me anymore. I was
going to say the sexy is, I can only imagine, because I've already got the
big mouth guard and the eye things to protect my lashes with the bonnet is a look. But yes, using of the creams are the best part. Okay. Wait, what about red light therapy early on in scar healing? I have the mask now too.
Yeah, no, I'm going and laying in the red light bed, minimum of 2 days a week. There's evidence that it works. Okay. So, and there is no known downside. And I don't know how you feel about this, but I don't even care if it works, because I'm warm. I'm getting to relive my tanning bed days, but I'm feeling like it's healthy, and I listen to an audiobook, and I'm not around, like nothing bothers me. That's my time.
You're forced to sit still.
Mental health benefits to that, whether it's helping me or not, but the evidence suggests that it's helpful.
Yeah, I swear, if I do something like that too, then I will make sure I do my skincare that night or something. It's like the snowball is happening, and I don't want to give up. Amelia Wilmington just got the body piece of the red light,
cool.
Where you can come in there and have treatment over your stomach at your post-op appointments. I did it. It was like I had the face one on and that one on. I was like in a red cave. It was great. My scar's too old at this point, but my scar looks great. Next category when it comes to implants and what we were talking about, it was kind of like implant movement. All of the different, when we talk about animation and, laying back and the, displacement. So how they behave in real life, how they typically look, laying down versus standing up, to how much movement is normal, and do things impact that over versus under the muscle, things like that. I know I've had movement issues in my journey.
Like if you put your hands together and you push, and you have under the muscle implants. See this implant, you see it better here. Like it's moving. Yeah. Okay. Well, it's under the pec. I'm activating the pec moves, the implant moves. I don't sit around at home doing this a lot. I do it Mondays and Wednesdays when I have clinics, so that patients that have under the muscle implants can see what that looks like. It does not interfere with my life. I'm in the workout clothes. I'm going to be doing my deadlifts and overhead press and all the things. I'm still trying to do a pull-up. If anybody wants to pray for me, it's not going well.
I've never done one in my whole life. I think they're overrated now. I've decided.
I'm really working, but it's not happening. I don't think God designed my lower body to be lifted by my upper body for women.
Absolutely not. I feel like I'm pretty strong, and I'm not even close. Like,
Mm,
not even an inch.
I hear
So
you. I
you're
hear
not
you.
alone.
But my implants are not the problem. It was the fact that I was a mathlete instead of an athlete, and then I worked and raised kids, and then was suddenly like, whoa, here's menopause. I guess I got to lift and eat protein. So moving on, implants under the muscle will move in a way that implants over the muscle do not move. If you think that's going to bother you, then that is in the, when you make your pluses and minuses, that is in the category of maybe put them over the muscle. And I have this conversation all the time, and I don't mind having it. I can have it as much as people want. If you rewound my conversation with patients about over versus under the muscle 18 months, 2 years ago, I was like, we should probably just put it under the muscle. Lower capsular contracture rates, softer look up here. You don't have to worry so much about rippling and implant show. And yeah, you're going to put up with that. It's not that bad. Now, well, what the heck changed? Why am I doing now? I went from like 90% under. Why am I at 60% under? Well, we got Motiva implants on the US market, and the data looks like the capsular contracture rates are the same over versus under the muscle for that particular brand. And so I'm like, oh, sweet. Okay, so if you get rid of the capsular contracture risk, then now we're looking at implant show. So what I mean by that is, like, when I see you in the office, generally I make you activate your muscle, so I'm not picking up your muscle. I want to know how thick this is up top, because if you go over the muscle, the only thing over the implant is skin and subcutaneous fat and breast tissue. Well, most of the patients that are coming to see me, shockingly, for implants don't have much breast tissue, or they wouldn't be here. And they're also generally not very heavy. So now we've kind of taken capsular contracture out of the equation. Now we got to talk about implant visibility. And so what I've kind of come to, and I'm getting a little off subject, I'll try to meander my way back, but if you're very thin and you want over the muscle implants, I think we should think about Preservé, because that pocket is so tight, I'm not seeing the rippling. If you're very thin and you don't care, we should put it under the muscle, because otherwise you're going to want to kill me. So, and very thin is under the muscle for me, or Preservé is where I'm at. If you have subcutaneous tissue, or you're like, no, look, I promise you, I will not be mad at you, then I'm like, cool, we'll do whatever you want. We can do a traditional over the muscle implant. When you're sitting up straight, when you're in a bra or a bathing suit, you're not going to see the rippling. It is generally naked, slouched over like this. You're going to see it if you, it's just an implant. It's not smart, right? It doesn't do, it just sits there. So those are some things to think about, over versus under. Now, going back to implant moving, your breast and your body and your skin move when you sit down and lay down. And I have news. We are getting not younger, and things are more lax and less tight from head to toe, and things move more. And sometimes I wake up and scare myself. Like, an old lady is in the bed with me because I looked at her elbow and there was like crepey skin there. And I was like, Grandma? And it's just part of life. So my skin is moving more than it ever did because it's not as tight. Your breast will move if you have any breast. Now, we're not talking about I'm 17 and I have very little breast tissue and I have a little implant. It's not really moving because her skin is so tight and her breast is so tight, it doesn't move very much. That's not my average patient. Most of us couldn't afford implants when we were 17 and everything was tight. And so for most of us, and of course it's going to be worse though. Every individual is different, but the older you are, the more kids you have, the more weight that you've, lost and gained and lost again, the less tight everything is. So the more mobile things are. So if you ask me the question, hey, Roughton, when I lay down, my implants move over, is that normal? I would say absolutely. Now, if you said, hey, Roughton, this is making me insane. When I lay down, I got to get a separate pillow for my implant to shove it up this way. Well, now we're talking about something maybe we can do something about. That I would call lateral displacement. And if you have under the muscle implants, it's totally normal to watch them fall over. And then you see kind of like, why are my ribs sticking out there? Well, your muscle's been elevated a little bit from the chest wall. So especially towards the kind of inner bottom, when you lay down, you can sometimes see that. If it doesn't bother you, it's not a problem. If it does bother you, well, we need to talk about risks versus benefits on whether or not it's worth trying to fix it. So that would lead me to, well, how would you fix it? The word you'll hear and see is pocket work, which means the scar tissue around the implant, if your implant is moving, by definition, the scar tissue, the pocket, is bigger than the implant. So we want to tighten the pocket, which we call lateral capsulorrhaphy. From the outside, we want to essentially imbricate or kind of close this down on the inside to force the implant back this direction. All kinds of frustration with doing that. It's generally a combination or one or the other of cautery and suture from the inside. And I essentially had given up. I was like, this doesn't work. It doesn't hold. It's not worth the risk of bleeding and infection. And I don't want to use the word bullied, but I was strong-armed into taking back one of my patients who was like, well, I'm not going to live with it. And I was like, well, it's not going to work. And she was like, well, I'm not going to live with it. And so we went back and forth. And I was like, fine, I'll do it. It's fine. And she was like, I really think you should add mesh. And I was like, gimmick, not going to work. Well, it did actually work quite well, and I've thanked her multiple times for strong-arming me and making me try this. I have started using mesh for anybody I'm going to do lateral capsulorrhaphies or pocket work for as a revision, the internal bra. In fact, I have some in my desk I can show you.
Yes, please.
And I've started putting it in prophylactically for my massive weight loss patients. Like if we've already kind of proven that the skin isn't holding, then I don't know. Anyway, I had to call a bunch of people back that I said, I can't help you, ma'am, and said, I can help you. So this is just a piece, and this is the Galaflex regular, and it's a little bit thicker than the Galaflex light. Ooh, now you can't see I'm not wearing makeup. This is what I like to use because patients don't feel it quite as much. And I put it in, this one's a circle, but it's rolled up. It's been in my desk for a minute. I put it in kind of as a sling. And if the problem is the outside, then after I do the pocket work and imbricate the side, I'm going to sew this in to essentially hold it. And it's on the inside, and it's just like a little hammock that holds up the implant off of where, I just closed it all down. So I think it allows everything to heal and seal before the tension of the implant comes right back and pushes back through all this stuff that we just did. So
what happens to mesh over time?
It is absorbable over time, which seems kind of weird. Like, well, I don't want it to absorb. You just told me I had to put it in as a hammock. But once things are healed and sealed, it doesn't tend to move much. It's why we develop waterfall deformities as we age, because our implants, once the implant is all in the pocket, it's not the implant aging, it's our breast aging a little bit and kind of becoming its own, at least for me, like it was in a different zip code from where the implant was. So the implant doesn't stretch too much once it's in there. The company describes it as it makes new collagen. Sure, we call that a scar. The new collagen is the scar inside the breast. But it does, I'm so much happier with it. So I appreciate my patients.
I've had mesh. I think what surprised me was how long it took to not feel it any longer.
I bet you didn't have Galaflex Light. I bet you either had Galaflex
Probably.
regular or a different brand, because that was unreal how much you could feel it in really thin women. It was all felt very bunched up, even though you're like, I swear to God, it was not bunched up when I.
Yeah. It eventually went away, but I was just like, wow, it's so funny. I feel it.
Yeah, and I'm so much happier with it for that reason.
Oh, good. Well, I'm still happy with it. A very common early post-op panic point we hear in Bustmob a lot is feeling extremely wide right after surgery. We hear that a ton. Like, how much of that is swelling, and do implants usually settle and move closer during healing? Like, a lot of people are like, where is my cleavage? And it's like, well, some of this is, I remember being so swollen between, my breasts too. It was weird. It was like, well, the more my swelling went away, the bigger and closer together they did look. But everybody seems so different. But that comes up a lot in Bustmob of like,
it must
just
not
feel big
persist because I don't see it. But I suspect what it is especially the under the muscle implant, the major is attached to your collarbone, your sternum, the crease, and on your arm. So it sits like this. And then I told you I'm going to cut it from the crease, so it's going to window shade up a little bit. So now you've got a muscle that's under a slightly different length tension. So it's bulkier because it's not all the way stretched out. And it's angry, inflamed, because it just got cut and operated on, and somebody shoved some implant up underneath it, like it's not having a good day. And so because it's attached up here, I think it can give the look of very wide or very muscular. I hear like I look like a linebacker. Like it's very temporary. That is not going to stay like that forever. The other thing that needs to happen is, so again, every patient's a little bit different, but the tighter the breast, the longer it takes for the drop in fluff, the longer it takes for this to kind of stretch out, because this inflammation needs to get better. This needs to stretch. So, and it's not, the implant is not up here. That is muscle. It looks very strange, 100%. And then it'll come down into the breast and it'll look so much better. Yes, there's swelling. Yes, I think it probably matters if you sleep on your side, not because it hurts anything, but if you're like a left-hand side sleeper, well, that side's gonna be a little bit more swollen than if you're a right-hand side sleeper, or if you don't spend exactly 50% of your time on one versus the other. Sometimes there was a little bit more bleeding or bruising on one side versus the other too, which can happen. It's a little hard to predict, and I know it doesn't sound like what you want to hear, but like in the first 2 weeks, I'm like, just try not to even look at it. Like, don't even look at it. You should make yourself crazy. You will see improvement, I promise, in almost everything.
How about rapid recovery, movements, the exercises, and or prehab type things? Are there things that can help this go away faster?
For sure. So just in the order that you asked me, rapid recovery is a game changer. And my surgeon, when I had my implants put in, he didn't do rapid recovery. I just did it accidentally because I went right back to work. So I had implants like on Friday and I was at work on Monday. So there was no like sitting around with ice packs, like we were moving. The more you move your arms up in the air, the more you're moving pec major, the more you're not getting so tight. So if you don't move and you do the old timey, like I do T-Rex arms, you're going to want to put your shoulders in to take the tension off pec major. And these are under the muscle implants for the most part. Over the muscle implants, it's really hard to have a bad recovery with an over the muscle implant. It's not too bad. And this isn't bad either. The more you lean your shoulders in, the more your traps and your levator are so mad because now they're not under the right length tension. And so you're getting all of this pain, which is simply from posture. So the more you can lay on your implants, you can give yourself some counter pressure here, you can move your arms around, the more you're just letting the muscles work and do what they want to do and not creating a secondary problem. So that's huge. And I get it. Like we are asking people to move the area that the only place in their body that hurts is right there. And you want me to move it? Like, what are you talking about? I just paid all this money to look great. Like, I don't want to hurt it. But I promise the more you move it, the better you'll feel and the faster you'll get to the end point where you want to be. Do I think it gets to a different end point? No, but you get there faster, which is what we're Americans. We're busy, gotta move. We got kids, we got jobs, we got bills. And then you asked me about prehab.
Yep.
And so prehab is a new concept for me, really. And you have to realize my career up until 7 years ago was taking care of really sick people. No, most people were pretty sick, especially compared to my population that I take care of now, which are all very healthy. And what we wanted was essentially the patient to survive the surgery. That's a little aggressive, but I wanted to know that their hemoglobin was such that they wouldn't bleed too much on the OR table. And I wanted to know that they had enough pre-albumin to heal, that they were eating enough to heal. Like, great. And they didn't have any major metabolic problems. Their diabetes was relatively well controlled. They weren't going to have a heart attack on the table. Their blood pressure was relatively controlled. Okay, fast forward. Now I'm in a population of healthy people that have trainers that are aiming for best. And so the question becomes, what do we need? What would be best? How to get back to life? Like we went from I don't want to die to I want to get back to the gym in 2 weeks, not 6. What are some things that I can do? So I think, and it's more important, I think, when you're operating on an area of the body where people can see it, but things like swelling and bruising, those things keep people in their house and they don't want to be in their house. And so things like arnica and bromelain, those can be really helpful for that. Does it work for everybody? No. Does it mean no one has a bruise ever? No. But there's some evidence that you'll have less bruising and swelling. So if that's important to you, and so let me tell you, I didn't care at all when I had body surgery because I was going to be covered. I cared a lot when I had my eyes done. I took every supplement I could take. And now, did I bruise and swell? Yeah, because that's just who I am. But like, anyway, maybe it could have been worse. So I do think some simple things like that are easy. Low side effect profile, potential benefit, we should do it. Then we have to think about activity. If you're already at the gym pushing a new PR with your deadlifts, like I don't think you're the person that needs to do 5 squats before the surgery. But if you're somebody who's been relatively inactive, simply doing some moving and being really committed to moving more, whether that's you walk, every other night for a few days, a few weeks, excuse me, before the surgery to get that amped up a little bit, your ability to walk and to walk longer and keep your heart rate up and sustained. Body weight squats work so many big muscles in the body. Like there's evidence that actually makes your recovery better, probably because you're better at engaging those muscles to go from stand to sit and sit to stand and sit to lay back. Like all of those things are important. Other supplements, maybe, there's some peptides people are looking at that have some benefit in joint surgery. Like maybe they increase healing. I think that there's evidence is out. I think that there's low risk to some of those healing peptides, and certainly like I'm willing to try them, but it's kind of something I'm not gonna bring it up because I think, especially when you think about breast augmentation in an otherwise healthy patient, like how much faster can she heal? Different story. I'm not at the peak of my health. I'm really doing this for X, Y, or Z. I'm having a bigger procedure. I'm having my arms, my breasts, my tummy done all at the same time. Well, maybe we should think about some of those things. Certainly the ones that cost almost nothing and have no downside, like body weight squats and arnica. We should probably do those things.
Are you referring people over to health now for that? Like, have you had people
I
ask?
am. Well, what happens is because of, and we were talking about this too, like, what do I talk about these days? I talk about my perimenopause symptoms. Like, man, do you know there's bizarre. I am into plants. And the other day I noticed myself noticing a bird and I thought, oh God, there's something really happening. I'm not sure what it is, but anyway.
I downloaded a bird app the other day. I immediately deleted it because I was horrified. But like I heard this bird and I had to know what it was. And I'm like, oh my God, it's happening. It's happening.
I can't explain it. I have a friend. She has the app. I was like, I'm not getting the app. I'm drawing the line here.
I deleted it right away.
Well, it's bizarre. And so my patients and I talk a lot about that. And not every OB is like kind of coming around to the hormone game, despite evidence that just said that transdermal estrogens are safe. Whether that transdermal, anything other than oral estrogens essentially are safe and will alleviate menopause symptoms and are not associated with heart disease as previously thought. So not every OBGYN is engaging the patient, but they're hanging out with me. We're about the same age. We're talking about how we're feeling. And so those patients, because they're interested. They've just been looking for a home. So we have Amelia Health. It's a functional medicine arm of our practice. I don't supervise it. There are PAs and nurse practitioners, but they're supervised by a functional medicine doctor that we contract with. But a lot of it is protocol driven, but very specified to your symptoms. And then it's a lot of trial and error. It's like trying to, if you're already starting this journey, like trying to figure out what dose of estrogen you need in your estrogen patch to make your night sweats go away. Like it's going to take a minute to figure out what that dose is. And then of course we're getting older while we're waiting and our ovaries are getting slightly less, effective. So it is a bit of a catch-up game. But that's been fun because it's making people feel better, which is what ultimately that's why I do what I do.
Yeah. I wonder too if the weight loss piece, like I wish I would have probably before my tummy tuck. I ended up losing about 15 pounds after, but I wish I would have lost it before. And this just wasn't a thing then.
Yeah.
Weight loss has become such an easier or more accessible thing for people. And so just usually having plastic surgery and then not working out it's sure you had a great tummy tuck, but oh my God, you could take it to a 10 if you start hitting the
Well, you
gym
can see
too.
the work that you're doing,
Yeah.
which is helpful. Like
Yeah.
being able to have the skin under tension again and doing a little bit of liposuction so it's more under a sheet, not a blanket.
Mm-hmm.
It's fun to be able to see, like I see muscles that I didn't know existed on my own
Mm-hmm.
body
Mm-hmm.
after that. So it's true. Like you can really see the definition of the obliques coming into the rectus on most women that have had a tummy tuck if they're also doing some core. But
Yeah.
sadly, they were doing all the core before the surgery and they couldn't see
Yep.
it. And so
Yep.
it's part of it.
Yes. Thank God for tummy tucks. Okay, one more. The kind of post-op bloating and weight gain thing. Everybody panics, and I truly understand it. Even though I know it's water to weight or swelling, it doesn't matter. You feel awful and you're like
Yeah.
horrified by yourself. So it's always a surprise. Do you recommend just not weighing yourself for X amount of time? Is there a time frame that you are like, yeah, you should not still be 10 pounds up, at this point? Or is there anything people can do?
Short answer, you have to give it time. All those expressions you see each other supporting you with, like trust the process, it happened to me too. Like if I could do something good for American women, I would get rid of every scale in every household. I just wouldn't be a thing. Like you would not be allowed to weigh yourself. Um, they can exist at the doctor's office, they can exist at the gym, but I just don't think they should be in your house because it's killing you. Like this is a big part of what I treat, which is crazy, right? I don't treat your brain, but I do sometimes. And so, A, stop weighing. B, those drugs are constipating. So you've got some of it is you truly are bloated. Like you got narcotics during the surgery, even if you don't take them after the surgery. Also, the body doesn't know that you wanted to have the surgery. So it doesn't know that this was great and you're super psyched about it. The body was attacked, it was assaulted, and it goes through a period of inflammation. That's part of healing. Inflammation makes little tiny blood vessels leaky to allow little white blood cells to go out into the tissues to do their job and to mend and to heal. Um, and you have more water in the tissues than you did before you had the surgery or I don't want to call it an assault, but the body again doesn't understand that this was a desired outcome. And so you are going, it is part of it. And there isn't any way around it. If you want to heal, you're going to have to go through an inflammatory phase. So you don't need to take a diuretic. You just need to wait it out a little bit. Like, don't have surgery 2 days before, you're trying to be in the super smallest outfit ever. Like, it's okay.
Yeah.
You're going to get there.
Yeah. And throw away the scale. I don't know. That's a
I
good
don't have
message, I'm sure.
I do not own a scale.
Really. I know I should just go buy my clothes, but I don't trust the clothes sometimes, so.
Again.
I know, I'm working on it.
Okay.
That was awesome and super helpful. Is there anything in all of that, again, you're so good at talking to women and trying to tell women the real thing that they need to know and think about and during this process, from consultation to kind of surgery. Is there anything we kind of didn't cover that is something that comes up in your consultations often?
I don't know. I mean, everybody is different for what they want. And I think most of my patients have gotten a lot of information before they get to me, which can be helpful, but also can make them crazy. Like I have patients that say like, well, what kind of a revision am I going to need? And I'm like, we haven't even had the surgery yet. And it's like, what are you talking about? But their bias especially if they're on the Bustmob group, is yes, it's a warm and supportive thing, but it's a Facebook algorithm. So if somebody has a complication or an open wound and everybody's looking at it, that goes straight to the top. If you posted, man, I love my implants, well, that's gonna be up there for 1 second. If nobody, likes it or talks about it, it just goes right to the bottom. And so we're all a little bit victims of the social media algorithms of fear. And here's what I tell my patients is that, look, yes, it's surgery and they're at risk of bleeding and infection and capsular contracture, and they're all about 1% of the time. I do not know how to make them 0% of the time, but you will have my cell phone number and you can let me know if something's wrong and I will fix it. And that's it. Like there's no amount of worrying about it is going to make it either. In fact, you'll either forget that they existed because you're in the 99% or you won't. You know what I mean? Like just 99% of the time, we'll never talk about it again. But if we need to, we'll talk about it again. And so I think it doesn't mean that you'll never get scared again, because of course you'll get scared again. But just remember that the algorithm is doing that to you. It's not that 99% of women need a revision or are going to have a terrible complication. It's that if they have one, it's going to go to the top of the group.
Middle Age Wisdom by Dr. Roughton. I like it.
Some grays in there.
Don't listen to the algorithm. Throw away our scales. I appreciate it.
Cool.
Work on this part of our head.
It's hard. I'm not saying that I'm good at it, but I do a lot of it. So.
Well, we appreciate your candor.
Awesome.
So
well,
much.
It's nice to talk to you guys today, and I hope you have a wonderful.
I know. Look, we made it. You've made it. Go do some
now that I take my
deadlifts.
blazer off so I can go to the trainer.
Get it. Thank you, as always.
No
Good
problem.
to see you, Dr. Roughton.